This AIF model, and we have two discussants, and each of them I'm going to only give them 4 minutes, okay? I'm a very good timekeeper. So first of all, we have Dr. Bruce Hyder from Florida State University. Let's give him.
Good morning, friends and colleagues. I'd like to thank Dr. Metz and her team for doing this type of work. I think it's tremendously important, and you're demonstrating that the phrase implementation science is no longer an oxymoron. I love the fundamental premise of the active implementation framework, namely that science has successfully identified some treatments that have worked well in the past for particular types of problems that our clients experience, and that some treatments have been tested and shown not to work in the past. Obviously, implementation research attempts to promote the former. I'm reminded of the findings of Ignaz Semmelweis, a Hungarian physician in the early 1800s, who found out that contamination from working with cadavers led to childbed fever in women who were giving birth in hospitals. And he clearly demonstrated through the use of a clever interrupted time series design that if you simply had your physicians and physicians in training wash their hands with an antiseptic solution, it would dramatically decrease female mortality when they were giving birth in hospitals. And he left for a while, went on vacation, and somebody stopped the hand washing, and mortality went back up. But his findings, although published, really weren't implemented on a widespread scale until around 40 years later when Pasteur and Lister came up with the germ theory of disease. And think of the untold thousands of lives that were lost because of the lack of an effective implementation science to get that information out there. I think that the AIF is a useful counter-control to the so-called dodo bird hypothesis, namely that all psychotherapies are equal, and it really makes no difference what technique you use as long as you have a proper treatment relationship. I think that the dodo bird hypothesis is a pernicious theory and quite harmful to human services in general, and AIF has a laudable reputation of it. Let me see here. I'm actually reading a book right now about psychoanalysis. I actually enjoyed reading about this, and the one I'm reading is called The Dangerous Method, and it's about the collaboration of Carl Jung and Sigmund Freud early on in the development of psychoanalysis and their relationship. And I find that back then they were wrestling with this idea of treatment fidelity. And here's a quote from this book that I think is just spot on, illustrating that the issue of fidelity has been with us for a long, long time. Freud actually wrote about the theory and results of psychoanalysis for about 10 years before he actually described how to do it. And it wasn't until his report of The Case of Dora, an analysis of hysteria, that he actually described how you actually do psychoanalysis, where you talk about sitting behind a client, lying on a sofa, using free association, using interpretation, talking about transference. And here's the quote from the book, A Dangerous Method, that I'm reading now. In science, any proposed method must be capable of being stated in formal terms. The method has to be capable of being formalized, at least in principle. Put another way, it must be capable of being set forth in a handbook, even if everyone agrees that the handbook is not quite adequate. A method which cannot be formalized is like a finding which cannot be replicated. However interesting it may be, it is not scientific. Freud was completely aware of this requirement, and the best way to reply to this criticism was to publish a manual, one that included interpretive rules, and Freud intended to do just that. And in later years, he actually did do that. So this issue that we're wrestling with here, we have a 100-year tradition in the human services of trying to figure out how can we convey to other folks what to do in a way that's replicable. The issue of fidelity, of course, refers to the practitioner faithfully providing the essential features of an intervention, omitting nothing crucial, and including no extraneous or contaminating content. And yet the issue of implementation deals with the uptake of selected interventions by individual practitioners or service settings. These are distinct but very different issues. Fidelity can be dealt with training, practice guidelines, algorithms, competent live supervision or surrogates by watching videotapes, and with treatment manuals. Volpe's systematic desensitization was then very early behavior therapy that was described in such a way that it lent itself to replication. And in social work, we have a couple of outstanding folks who've done something similar in the form of Myrna Weissman, who came up with interpersonal psychotherapy back in 1984, and Dale Steckety's self-help books for problems like obsessive-compulsive disorder and compulsive hoarding. These have been actually tested in a real-life context and shown to work pretty well, sometimes even without therapist involvement. And I think that's a tremendously valuable legacy in terms of getting things out there in terms of implementation. In Metz's team, we see them having selected 6 services for use, some of which are reasonably well managed, manualized and teachable, and others are not. PSIT's one of them, the Strengthening Families Program, and Success Coach. Those are pretty well operationalized. Adoption support, educational advocate, not so much so. Now, here's one little piece of advice. You describe your model as consistent with what you call evidence-based or evidence-informed practice. This structured approach strikes me as far more potentially effective than the usual train and hope model, where clinicians are trained and then administrators hope that they use them. They're pilot testing this, and in the initial paper that I received, I didn't see anything about actual outcomes. So I was interested to see that in the future, you actually provide data showing whether or not the kids and families are improving while you're implementing the fidelity checking and trying to disseminate this. So let's try and keep that in mind. You also use terms like evidence-based programs, evidence-based and evidence-informed practices. And I'd like to give my opinion that what this is got very little to do with evidence-based practice as defined by the originators of this model. Evidence-based practice is a decision for an individual clinician to make a decision about what type of service to provide a client. Here's the definition from the originators of evidence-based practice. It's a 5-step decision process about what to do. It's what the clinician does in conjunction with the client. This is quite different than what we heard described, wherein administrators describe or decide, well, we're going to implement these interventions in our agency, and all of our practitioners are supposed to provide them in a fidelity way. That may be good, but that's more consistent with what's called the empirically supported treatments initiative. It's really not evidence-based practice, which is much more of a bottom-up approach to making clinical decisions. So while I really like what you're doing, I like empirically supported treatments, I think there's a good role for that. So I would encourage a little bit of use of language to try and avoid contaminating this type of work with the process model of evidence-based practice. Certainly evidence-based practice uses much more than research evidence to make decisions. Ethics, client preferences and values, circumstances, clinical expertise, those all go into the evidence-based practice model equally well. And I'm finished. Thank you.
Because I'm a social worker and I'm always assessed to be an amiable, which is an A that a lot of you have. But when I'm becoming a moderator, actually I'm a driver. So today, I think that Allison's talk is just wonderful, talking about drivers, because I really drive Dr. Thayer to talk really fast so he can finish his talk. And I would like you to keep all the questions in your mind right now, because we do have a last discussion. And Dr. Boer and from UT Health Science Center in San Antonio. Welcome her, please.
Thank you. So I just wanted to comment to Allison that was an excellent presentation. The model is so very valuable to junior faculty like myself who are trying to pursue implementation research in various settings. And so as I was listening to the talk, and I have reviewed the synthesis of the research in the past, and it was extremely valuable to my thinking early on. And so I started putting it in my head to what I'm currently working on, and just as a quick context is I work with the DoD in Fort Hood, Texas, with the behavioral health system there, and where you have ongoing clinical trials funded by DoD evaluating and establishing evidence, empirical support for certain traumatic exposure therapies, et cetera, with active duty soldiers. So, in my mind, I'm looking to the future for implementation. How do we get DoD behavioral health providers across the country to use these therapies? And we already know, and so what I'm going to probably pepper you with is many different questions that I really should pay as a consultant later to help me with. So how do you apply this model when there's already, you're not starting from scratch. You've already got some policies in place that people are ignoring. You've already got training underway that people did a year ago but never had the internal support or leadership or good coaching or time. We have constantly, as every agency and every helping profession setting often deals with time limitations and time to retool. That was one of the most key pieces that I heard today. People can't see themselves stopping to learn something new, even when they recognize how important it might be for client outcomes. So I was trying to identify, well, where are we? What stage are we in? And we're in between, probably. And we probably need to pull back. I keep going in and out, and address where we're at in order to measure sort of where we should go. And then the other piece is, did you have some resistance among your implementation teams, and how did you address that? And then how do you deal with turnover? We know that we all face that problem where individuals leave agencies and all of that great knowledge about implementation, which seems so important for long-term sustainability of these great practices. And the idea that I almost started thinking as implementation teams are an intervention in themselves. So we need evidence for implementation of implementation teams, and then how long do they last? And I'm sure you'll look to that in the future. Were they sustainable? What made them sustainable? Because they seem extremely important, and they are akin to continuous improvement practices that have been around for a long time, but they seem much more robust and valuable in terms of linking with clinical outcomes. So I really appreciated that. And so I'm walking away wanting to apply this to my research, to propose it as a model to adapt for what I intend to do, and I thought it was very valuable. In addition, one thought for sustainability was the idea of champions. We know about champions in the literature. So did that come into play in terms of the teams and the leadership that you might identify within those teams? What else did I have? I'll summarize so we have more time for questions, but basically as a researcher trying to do this kind of work in a different clinical environment than child welfare, in a different infrastructure and institution where leadership is a different beast in the military. You've got chain of command where things are so set in stone about how things are done. And how do you develop leadership within teams when they all know that the leader is really the person down the hall who calls the shots? So this will be really interesting to think about how to apply this model. So I'll conclude with that. Thank you very much.